Welcome everybody to this LTC COVID webinar. Today we're going to talk about the impact of the COVID-19 pandemic on unpaid carers in particular. And I'm extremely pleased and happy that we have with us somebody who's actually got lived experience of what's happened and what that means. We will then have an overview of early international evidence, academic evidence mostly, but also from some NGOs in the impact of the pandemic presented by Clara Lorenz. Then we're going to have a whistle tour of ongoing studies, and this will be an opportunity to also see if there's opportunities for collaboration, discussion, very quick discussion on networking, maybe of different types of studies and seeing if there can be some shared learning from that. So we'll have a lot of very short but quick presentations, but we'll make sure that we can share the slides and contact details so people can find out more about each other's work afterwards as well. And we will then conclude with some early findings from India, already published, in fact. So I'm going to stop here and hand over to our first speaker, who is Jackie Powell. Jackie, we're very honored that you've made time to speak to us today. And the floor is yours. Just a reminder to everybody else, please mute your microphones. You can write comments and questions in the chat. I will go back to this at the end of the webinar to bring up any questions that have emerged, and also people might be answering as we go along. So please keep muted, and the floor is yours, Jackie. Thank you so much for joining us.
Thank you. Yeah. Hi, my name's Jackie Powell. I'm 56 and I'm from Leeds. My husband is Keith Powell, and he has Alzheimer's, but well, like most people with young dementia, he also has features of other types of dementia, particularly frontal lobe dementia, which is quite prevalent in people with an early diagnosis, and also some PCA features. He was diagnosed when he was 53, and in Leeds, we're lucky enough to have a young dementia team and a young dementia day centre. So he went to this day centre daily, and it's there to help people try and keep the skills as long as possible and keep them independent. But as with early onset dementia, the problems are they lose their skills or can lose their skills fairly quickly. And that's what happened to Keith. He lost his skills and began to communicate less and became more and more withdrawn into his dementia. The day centre provided quite a lot for him, even though he didn't participate. He still enjoyed just being there and being part of what was going on, and there was enough stimuli there to keep him going. Really, he withdrew from things like watching TV and things like that, and the last thing that he really enjoyed was food, and he could listen to music. So the day centre was there 5 days a week, and he was supported quite well there. But then 3 days before lockdown, the centre had to close its doors due to the coronavirus. It affected him quite badly, and I saw the decline over 2 weeks, really, where he did actually feel like he did fall off a cliff. And his behaviours became more repetitive, his behaviours became more challenging, his cognition wasn't as good, and his mobility really started to suffer. He stopped wanting to eat, and he became more reliant on me, wanting me to do things for him, like helping with his transfers from chair, take him to the toilet, take him to bed, even to the point where I had to feed him because he'd eat half his food and then he'd just stop doing it. It's just like he lost all his abilities, just seemed to start going to sleep, basically. He became more of a falls risk, and he had a couple of falls where he did actually hit his head. So anybody who's got dementia, which is like a brain injury, hit the head, it's never going to be a good outcome. And he got where he's shuffling, where he could shuffle like one step the length of a foot, it became like 2 centimetres, 3 centimetres, and he needed more and more help. I already had night carers in anyway 3 nights a week because he didn't sleep very well. He could be up anything from 15 to 40 times a night. The night carer, it became more difficult for her to look after him during the night because he was up so many times and he needed more assistance. and social services and the memory support services had to be invoked, and we had to come up with a plan of what we were going to do to help Keith and provide him with the care and support that he needed, because it had gone from me being able to look after him to him now requiring 24-hour care. So within 2 days, he was actually put into care. Obviously, we were limited where we could take him because of lockdown and the COVID. And literally, I had to drive him to a care home 25 miles away to say goodbye to him in a car park, basically. I felt like I'd abandoned him. Obviously, he'd relied on me for his communication and because I could understand him and read him. And I literally had to walk away and leave him with a load of strangers. And I didn't see him for 7 weeks. Now we have established some kind of routine where I could go see him in a car park. Then now, because it's in Bradford, lockdown's on again and I can't see him again now. So, you know, where do we go from here, basically? He went into care. The care package obviously stops after 28 days. So I've been looking after him at home for 3 years, and, you know, you get your 28 days grace, and then the PIP stopped. Everything stopped. My carers allowance stopped. I've been looking after him. I'm in a pandemic. You know, I'm not a paid. I get paid. Get paid a carer's allowance, or I did, which works out something like 40 pence an hour. And where do you go from here? There's no safety net there for you being a carer. You're just thrown on the scrap heap, basically, and you have to fight for everything that you can get. You know, he's in a temporary care placement. You know, where do we go from here? How do I start to build my life, but still include my husband? It's been an experience that I won't wish on anybody, and being part of the Young Dementia has a little bit of a safety net because of the services that sit within it. But people that don't sit under that umbrella of Young Dementia, you know, they could be in a lot worse situation than me. I mean, financially, it's bad for us, but, you know, I've had to give up work, but there's people out there that have got young children. You know, dementia it's indiscriminate. It doesn't just affect old people. You know, everybody says, oh yeah, my grandma's got it, or my granddad's got it. I'm sorry, it's dementia, but it behaves differently in younger people, and we need to get more awareness out there and more understanding and more support for those people, because it is financially crippling for some people. It's heartbreaking. Thank you for listening.
Thank you so much, Jackie, and our best wishes from everybody here. And thank you so much also for helping us see the relevance of this work we're doing. Sometimes, as many of the people of this call are going to be academics, we do speak to people, but to really hear from you also, and to also see how directly it's impacting you, and all these things that we read when it comes from interviews, to hear them from you gives it so much more power. And I really hope your voice is heard, and we will do our best as well to help share your experience. Thank you again. So to go from this very personal individual experience to an overview of what the early findings are so far, I'm now delighted to speak my colleague Clara Lorenz. And Clara, the floor is yours for 10 minutes. Thank you.
Thank you, Adelina, and thank you very much, Jackie. As Adelina said, I'm going to take you through a bit what's in the literature, and it's kind of building on some of the things that you said, but obviously it's a bit of a broader view. It includes carers of people with dementia, but also carers of people with other care needs. I'm sorry, I'm going to turn off my camera because I'm worried about my bandwidth, but I hope you can hear me talking. If it stops, then Adelina, please tell me. I'll just go and share my screen now. Okay, so I'll be talking about the impact of the pandemic on unpaid carers so far, and the measures that have been adopted to support them. And why is this not okay? And I will look at, I'll take you through this very briefly, and we're working on a paper to get this out soon, so hopefully there will be more detail, and it's also very much work in progress. But I will basically look at two parts. So first, what do we know about the impact of COVID-19 on unpaid carers based on a rapid literature review? And here I will split between the experience or the evidence we have on people providing care in the community and evidence of people supporting people with care needs living in residential care settings. And then in a second aspect, I will look at what measures have been adopted so far, and that's very much based on the review of evidence that we conducted as part of the LTC COVID work, so the different country reports and the information that came out on unpaid carers there. So again, I'd just like to point out from those country reports that evidence from there is not exhaustive, but this is what's been brought together. So this is just very briefly, and I'm sorry, it seems to be all sorts of things showing up here. So this is the search strategy that we used for the rapid literature review, and I'm just going to put this up here, but basically we looked at the scientific literature, and we also looked at, in this Med archive, we looked at literature that is basically not peer reviewed yet. So, but we looked at what's available, what studies are going to come out, and included those where we felt that was good to do so. And then of course we looked at the grey literature, because a lot of relevant reports have come out from voluntary sector organizations. So in total there were 18 resources that reported on evidence on unpaid carers and how people experienced providing care during the COVID-19 pandemic, and what impact it had on them. So here, this is a slide about carers in the community, and we kind of tried to divide it into 4 groups. So there was some evidence, particularly from the UK, that actually there's quite a large proportion of people who have become kind of new carers. So these are people who are supporting someone outside their household. And there is ONS data, there is a data the National Office for Statistics published that said that 48% of people in the UK have taken on some kind of supporting role. There is also evidence that the intensity of care has increased for a lot of carers, and for some carers it also has reduced because of shielding, because of transport issues, but overwhelmingly it seems that the intensity of care has in the UK on average about 10 hours has increased. Then we have information on issues that carers describe. So one of the most prominent issues that came out was worries and concern about contingency planning in case the carer gets ill. So what that means is that what happens to the person that they provide care for, if the care, or what happens, who else would take on if the unpaid carer becomes ill. So that was that became what was picked up in evidence from the US, from Canada, Australia, and the UK. And the question of, well, how to put in contingency planning if there are no unpaid carers or if the care is very complex. Then there were worries and concerns about the person with care needs. So them getting an infection, how would the unpaid carer manage that? But also, and perhaps that was sort of came out, I found more strongly, was the impact that the COVID-19 pandemic, and I think that picks up on what you said, Jackie, earlier, has on the functioning of people, the sort of disruption of daily routines, the disruption of services that normally support people's everyday lives not being available, but also for some people, the recovery. So there was a study on people with anorexia nervosa who the carers were concerned about how the recovery would be impacted. Then there were aspects around financial concerns, employment concerns. A survey by Carer UK found that family carers incurred more costs in terms of bills, in terms of buying food than prior to the COVID-19 pandemic. So that obviously is an important issue. Then there was evidence around family tension and conflict, of being around each other all the time, about not having times, having breakouts, having relationships affected by that situation. There was evidence from the early period of the lockdown in Australia and the UK, where carers were concerned about access to groceries and pharmaceuticals. And the issue there was interesting, was a survey amongst all the carers in Australia, picked up on the carer hour that was introduced there to have sort of separate shopping hours, and them finding that there were a number of issues with that, including, for example, the need for public transportation and the issue of access around that. And a similar thing was found among a study on young carers in the UK, where with the adult having to shield, it was young carers relying on public transport having to get to the grocery stores. And then there were experiences with support and service structures, and it seemed that a lot of people felt left alone by services, understanding that the focus was currently on healthcare service, but still feeling left alone. However, there were pockets of innovative care practices that people seemed to find very helpful. In terms of what carers experienced, what perhaps the outcomes were issues around isolation, around stress, mental health impact. So there was reports of anxiety, depression, but also aspects of well-being. And I thought it was interesting that in the UK data, it was actually found that carers, and from the data, I cannot say how intense those carers were involved in the care, but it seemed that people who provide care felt more useful and enjoyed day-to-day activities than non-carers in this category did. But I would suspect that probably there may be a level of intensity that may play a role there as well. And then we found information around needs and wishes. So it was interesting that there was only information from the US and from the UK, and participants in the US, these were people of carers with dementia, had less expectations of their government, and also that sort of reduced the wish for having support, whereas there was data from the UK that suggested that the wider population would like carers to be better supported. There was also specific needs. There was a need for clearer information considering the complex care situations that people experienced, access to PPE, access to virtual training and enjoying the benefit of having access to that. But also one study from the UK reported on the issue of social responsibility of other carers, of other people out in the public behaving in a way that actually then helps carers to protect the people that they support. So this is very briefly what we found on carers in the community. What we found on carers in residential care settings was a lot less, but we found that carers were largely affected by visiting policies, as Jackie had reported that as well. And there's only one study from the Netherlands that looked at how they started to enable visits again. We have information from the US and the UK, where carers described that they were concerned that they could no longer monitor the health of the people with care needs, and information from the US and Australia, where they were concerned about the quality of care that the person they supported received without them being there to monitor. That resulted in, or one of the experiences that was reported was stress. So the stress of not being able to visit, although a repeat survey amongst carers of people with dementia in the US suggested that that's slightly reduced over time. So that stress seemed to slightly wear off, but there may be all sorts of issues with that's really just observing the raw data that's being reported.
1 minute.
Then, oh yes, I'll be very quick. And then in the Netherlands, where the ability to visit also brought stress because carers were worried about bringing in infections. And in terms of needs and wishes, in the US, there was a wish for testing of staff and residents, and also a willingness to contribute. So this is in a nutshell what we found on residential care. And then in 30 seconds, very briefly, this is what we found from 30 reports published on the LTC COVID website. And there's a report that's already available online. And it really shows that in terms of what's country reports report, what is available to support carers, are mostly virtual support interventions, guidance and resource documents. In less than half of the countries, their financial support is in place. aspects such as emergency support structures in place, the support with navigating restrictions such as access to shops, for example, or responsibility of healthcare providers for unpaid carers is all very small. I think I'll just stop here then.
Thank you. Thank you, Clara. And we will be sharing the slides, so you'll be able to take a closer look at all these details. And when Clara's paper is out, we'll make sure to share it as well through LTC COVID, so you can get all the details. So thank you so much. So now we're going to go through this very fast overview of lots of ongoing studies. Some of these studies will be recruiting, and we will be sharing the links so you can also take part and you can help spread the word. And I'm delighted, first of all, welcome Professor Irasema Leroy from Trinity College Dublin and the Global Brain Health Institute. She'll talk about coping with loneliness, isolation, and COVID-19, hearing the voice of carers. The floor is yours.
So thanks very much, everyone. I just have 5 to 7 minutes, so I'll go very quickly. Adelina, please warn me if I go over. So thank you very much to previous presentations. They're very important and interesting and align with this very closely. So what I'm going to tell you about very briefly is a survey, a global survey exploring loneliness, social isolation, and burden of care in care partners and families of people with dementia in the context of COVID-19. And this is a survey that was launched a couple of months ago now and is starting to build momentum as we're getting more international partners. So I'll just let you briefly into what we're doing. And I hope that some of you may be interested and potentially want to take part as respondents, or also as access to further groups of respondents who may find this interesting, providing data, but also for the experience of validating what they're experiencing by taking part in the survey. So I think for this group, of course, I don't need to stress the point that over 80% of people with dementia are dependent on a non-professional care partner or family member. But even before COVID-19, more than 90% of dementia care partners experience significant burden and higher levels of loneliness and social isolation. And really the point of focus on these two aspects, because there are many, many aspects of the care partner experience that we could look at, but particularly loneliness and social isolation, again, because of the lockdown circumstances and because of the tremendous impact on morbidity and mortality. So I'm just really making the point here with a slide because I'm coming from Trinity College Dublin, and we've started this from the Irish context. But the Irish word for loneliness is, in fact, I won't pronounce it. I'll leave it alone because I don't speak Irish. But essentially it means alienation and solitude, but it's also the word for grave. So you can see the depth and the impact of what loneliness and isolation can be. So I'll just move through this. So the key aims, I'll just run through these goals. First of all, to explore care burden, loneliness, and social isolation in these particular people. The second goal is to provide access and evidence on NDD or neurodegenerative disorders care partners to policymakers, communities, and care organizations to raise awareness, trigger support, and inform policy. So even though we're targeting individuals, we're also partnering with several organizations and agencies, and the goal is to feed back our finding to those, like, for example, the Alzheimer's Society Ireland, the Alzheimer's Association in the UK, the Lewy Body Society in the UK, and so on. And of course, the third one is to link with the wider international survey of COVID-19 related loneliness and social isolation. In other words, the CLIC survey, which is the basis for this, is really targeting everybody, every adult over the age of 18, but within that, we have embedded specific questions for care partners. I'll just run you through those very briefly. So just to make the point that the inclusion criteria is absolutely everybody over the age of 18. So I hope everyone on this call will please do it for their own purposes. So these are the embedded care partner questions. So if you answer as a respondent that you are a care partner or a caregiver, then it opens up different boxes, which then specifies, are you the care partner for an adult or a child? And then it specifies what type of care and for whom. In other words, a person with a long-term condition that's either physical health, with mental health issues, dementia, or with intellectual disability. So those are the 4 basic characteristics. And there's also further questions about the long-term conditions and how the care is provided. Also then asking how the ability to offer care has changed or been interrupted, with a bunch of options, as well as an open text. Some questions on care burden. And these are where we have the translations and the participating countries thus far. And some of these are just coming on board. But when one goes into the survey, one can click on the language. So in other words, you could be a Spanish speaker in the UK and access the Spanish version. So this is the last slide, just to really point out where we're up to right now. So we have had 11,000 responses for the overall click survey. Now, of those, we have about 3,000 care partners. Now, at this point, we don't know whether they are care partners for people with dementia or other conditions, but just generally falling as self-described into the care partner role. And the bulk of these come from the USA because we've been able to partner with the Alzheimer's Association, and they have a clinical trials registry, which they sent the email, the survey to. And as you can see at the bottom, there are some countries that are literally just coming on board, and that's because we were still waiting for ethical approval, as well as the translations, which have now been done. But I'm very pleased to say that some countries like Romania, we don't have a lot of responses yet, but getting data for a country like Romania will be absolutely fantastic, because we really want to try to understand how people in these different countries across the world are managing these issues. So I'm going to leave it there, and please, I'll ask everybody to click into the survey, which Adelina, I think, will share with everybody. Thank you very much. So hopefully that's less than 7 minutes. And just to point out, the survey takes about 15 minutes, so it's fairly easy and straightforward. And embedded in it are the validated scales, like, for example, the UCLA loneliness scale, the de Jong-Bierfeld scale, and also the live in social isolation scale. And all those people are partners on this project. That'll stop my share. Okay.
Thank you so much, Irasema. And I have circulated the link in the chat box. We will also put it on the LTC COVID website, and we'll also be tweeting it. So if you can help spread the word, that will be much appreciated. And any volunteers, maybe, do you want volunteers to translate to more languages? That we can also try to get for you. So thank you so much. I'm delighted to next invite my colleague from another project, Nicholas Farina from the Brighton and Sussex Medical School. He'll present on how has COVID-19 affected the quality of life, well-being, and care of people diagnosed with dementia and their family carers, using a nested study for the time for dementia sub-study. Thank you very much. The floor is yours.
Okay. Thank you, Adelina. Yes, and well done for reading out this long title. So, yes, today I'm going to present to you about one of the studies that we're currently running within the Centre for Dementia Studies that's focused on COVID-19 and the quality of life of carers of people with dementia. Just wanted to start off by highlighting that the primary investigator for the study is Dr. Stephanie Daly, and unfortunately she couldn't be with us today. She's on annual leave, and the study is funded by the NIHR Applied Research Collaboration Kent, Surrey and Sussex. So the study's aim is to understand the quality of life and care implications of COVID-19 pandemic on people living with dementia and their family caregivers. And as you may have noted that within the title, this is a nested study from the Time for Dementia study, which is an education initiative which we are getting medical students, nursing students, paramedic students to spend time with people with dementia and their families, not in a clinical capacity, but as a means to just kind of understand or to allow for the students to understand how it is to live with dementia and how it may progress over time. So that's a novel initiative that's going on a lot in the southeast of England. And the main benefit that we have is that we've been capturing some data prior to COVID-19 related to whether the Time for Dementia program may have a detrimental effect on people with dementia and their carers' lives. And there was no evidence that this would be the case, but it was just something that we were doing just in case. But this does mean that we have the opportunity to continue to follow this cohort during the COVID-19 period, because we've got good contacts with these families. They provided evidence and data prior to COVID-19, and we thought that it would be quite a kind of a pragmatic approach to kind of follow this sample up over time. So this is a pragmatic study design. It's something that is a longitudinal mixed methods design as well. So from the 350 people that we have recruited and tested prior to the COVID-19 outbreak, we are following up 250 of them as part of a quantitative study. So we're asking some of the same questions that we asked pre-COVID-19. We've collected about 250 participants currently, or already, that was due during the first wave during the UK. So the main lockdown period. So this was kind of before July this year. And then we are following them up again in September time. And this is, this was slightly a kind of a limitation of the grant, because we only had a 6-month period to collect this data. So September is the time when we will follow them up, and I've labeled this the new normal, but obviously based on current lockdowns up north and various other things, this may not be the case. But alongside these quantitative data that we're collecting, we're also planning to have a longitudinal components where we're focused on qualitative interviews to kind of get the in-depth insights into how family carers have been coping with their day-to-day life, providing care, their quality of life, both during the lockdown period, but also in September, where the restrictions are likely to be less severe. But and the idea is that this means that we not only have cross-sectional data, we also have this kind of longitudinal data so that we can see how things change over time. With regards to the quantitative outcomes, we are looking at carer quality of life. So our main outcome would be the CDEM core measure. There's a link on this slide here if anyone wants to look at the questionnaire that we used. It's free to access, and it's very much specific, looking at the quality of life of someone who's caring for someone with dementia. And we do have other measures of socio-demographics and the quality of life of the person with dementia, the severity, and how that's been changing over time. And we also, as I said before, we do have these qualitative interviews to better kind of delve deeper into the experiences of the COVID-19 pandemic, as well as identifying any factors that have sustained, improved, compromised quality of life over this period of time. So hopefully there'll be a bit of an iterative process, so we can maybe get some more questions in during the last visit to kind of to learn from both sides of the data. I'll just kind of end here with some considerations. I mean, so first of all, this is a sample population from the southeast of England, and it is a very white British sample. So obviously that's going to limit some of the conclusions we're able to make. The other side of things is that this is largely a spousal care sample. Again, so this again may prevent us from making too many conclusions about other family dynamics of care. The naturalistic nature of this study also means that we can report on associations, but it's quite difficult for us to make any statements on actual causation. But that is an inherent problem with a lot of observational research. And as I alluded to before, one of the key problems we have is that we don't know what September will look like within the southeast of England. And obviously, if we are under new lockdown measures, this is going to make our data sets a little bit more difficult to interpret. But obviously, I'm happy to answer more questions later on. So thank you for your time.
Thank you very much, Nick. And we're going to stay in the UK for another presentation, but now the topic is a bit different. We're going to hear about law for dementia carers, and we're going to have a presentation from Karen Greenhow, I think I pronounced it okay, I hope, and Lena O'Connell from TIDE, which stands for Together in Dementia Every Day. And the title of the presentation is Law for Dementia Carers, understanding the impact of legal issues for carers of people living with dementia during the pandemic. And thank you as well, personally, for putting us in touch with Jackie. It's completely enriched these workshops. I also thank you for this interaction. The floor is yours. Thank you.
Thank you very much for this opportunity. I'm Karen Greenhouse. I'm the project manager overall, and Lena will contribute slightly further into the presentation to talk about the methodology. This is just the context really of what we're doing is the Law for Dementia Carers is a 2-year project that's funded by the Legal Education Foundation, and it's a partnership between the Life Story Network stroke TIDE, which as Adelina says stands for Together in Dementia Every Day. This is a charity which covers the whole of the UK, and its purpose really is to give a voice to carers and to connect with carers both on a sort of individual and collective basis, so that they can make their voice heard both for themselves individually, but also to influence national policy and local policy. Hence the connection that we've made and facilitated today with Jackie and talking about her story. So it's a partnership between our organisation and Making Space, which is a care support charity provider. And we also have support with the Manchester Law School's Dementia Law Clinic. The project was set up to focus on legal rights of family carers of people living with dementia. And it started back in November last year. Just moving on from that, our objectives were originally to develop a training program for carers, which was to be delivered face-to-face or more likely now online as part of a general carers offer that the TIDE promotes. And was also a sort of flip side of that was to develop a training program for health and social care staff as part of the social prescribing model. And that was originally focused on the Greater Manchester area, because in Greater Manchester we have a health and social care partnership operating. Finally, our objectives was to produce some guidance for relevant bodies to emphasise the importance of legal support as a key health outcome for carers. Moving on, with COVID, we decided we were going to repivot our project temporarily, hopefully temporarily. The introduction of the Coronavirus Act in March 2020, the emergency legislation, has quite significant impacts potentially on carers, particularly in the area of health and social care. And so what we were wanting to focus on was gathering carers' views on that impact. And the aim of doing that was to use that and contribute to the 6-month review of the Act that's scheduled in September or sometimes in the autumn. So it's to influence the government review of what was going to be happening and what would happen with the Act going forward. So what we've done so far is, as part of the purpose in terms of informing carers, we have, as a project, produced an easy to read guide of the Care Act easements and what that means for carers. And we followed that by a free webinar, which was which had over 200 people registered for that particular webinar, talking about the legislation, which included the Coronavirus Act, but it also looked at other pieces of legislation that were relevant to carers at this particular time. Some of that information is information that's important for carers more generally, but some things have become particularly pertinent at the moment. And both of those pieces of information, the webinar and the easy to read guide, are available on our website. So linked to that, there has been, you may well be aware of the One Dementia Voice open letter that went through to Boris Johnson and Matt Hancock about the role of care and informal carers in terms of visiting care homes and the distress that that's currently causing, which is a piece of work that's complementary to this project. And we're also involved in producing surveying the partnership in Greater Manchester to see whether having that partnership is actually affecting their ability to coordinate across the piece. And I guess it's very pertinent today that we've got a major instance initiated in Greater Manchester, given the increase in outbreaks at the moment here. Moving on, Lena's just going to talk about the approach that we're taking in terms of a carer survey.
Yes, so the survey is part of our own study initiated by Tide in partnership with Making Space and Manchester's Dementia Law Clinic. It's not an academic study. But we haven't gone for an ethics approval. Well, we're a charity, so as far as we know, we don't have to do that. What we've done, we have created a survey with questions focusing on carers' legal rights and how they've been affected by the lockdown and other measures. We've since checked the questions with someone from, with Dr. Clarissa Giebel from Liverpool University, and we sent this survey to our members, and we've got over 1,000 members, including carers and former carers, and we shared it with other carers networks. So we've had 180 responses so far, so quite a lot of data. It's still live, and after Jackie's story was published in Yorkshire Evening Post recently, a couple of days ago, we are thinking that there will be more responses. We are then going to follow this by semi-structured telephone interviews. Quite a few people have opted in, said they would like to be interviewed. So we're looking at 12 interviews. We would have liked to have done more because but we don't have the staff, the manpower to do so. But we'll try to do 12 across the 4 nations. And we're hoping to, we'll analyze this thematically, and we hope that the findings will help us to influence the legislation in autumn. So the deadlines are quite tight, quick turnaround, and that's where we're at the moment. So if you have any questions, I'm happy to answer about the survey. So these are our contact details. I think that's 7 minutes up.
Thank you, that's perfect. And if anybody wants to find out, so here's where you can find out more about the study. We're also happy to share any links to the website as well, or you can also write them in the chat if you'd like anybody to find your website, for example. So next we're going to move to Germany, and we're going to hear from Moritz Hess from the University of Bremen, and the project is called Domestic Care in Times of Corona. Welcome, Moritz, and thank you so much for joining us.
Yes, it is an honor to be here. I've had really very good input in the last 45 minutes. Can you see my slides? Okay, nice. So topic of my presentation today is domestic care in times of Corona, and it is done in Germany. I would like to emphasize that we are a large team, so I'm just, one small wheel in the machine running this study. So PIs are Karin Wolf-Ostermann and Heinz Wuttgang. They both work at the University of Bremen at the Research Center for Inequality and Social Policy and Institute for Public Health and Care Research. I would also like to emphasize that our study is still ongoing, so unfortunately I cannot present any results. Okay, so what is the background and what is our aim? What is our research question? So I really tried to squeeze this in basically 2 bullet points. In Germany, the bulk of long-term care is done at home, and it is done by daughters-in-law, and wives. So mainly females doing, or women doing domestic care. This is due to the still conservative German welfare model with the male breadwinner model. And this might have implications for later. So the question is now, if a lot of people are doing domestic care, taking care of their older, frail relatives, how has COVID impacted these carers? And then maybe the more interesting question, what can we, what can the government, what can employers, but also what can we as scientists do to support them while giving care in times of COVID-19 in specific, but you could also maybe draw some implications for pandemics in general. Two sub-questions are, and the first one I find in particular interesting, so how does this potential impact of COVID-19 or care arrangements differ by gender, by SES, so by socioeconomic status, and maybe further variables? And one could speculate here that probably as women are doing more care work, that women are stronger affected by COVID. And one could also hypothesize that COVID-19 might increase gender inequalities. There are some first studies on childcare where it seems that in particular the mothers are taking over much more work now as kindergartens, daycare institutions are closed. And I think the main thing we would expect are negative impacts of COVID-19. You could also speculate about a few positive ones, people having now more time. I think in the second presentation, we talked about this potential increase of well-being, but the focus should be that it gets, let's put it bluntly, worse for the carers. Methods, really briefly, if you're interested, just send me an email. We're doing an online survey with carers. We are cooperating with one of the larger public healthcare insurances in Germany. It works in Germany like this, that the healthcare insurances also provide the long-term care insurance, so they can really identify those who are officially registered as carers. This relates to the third bullet point here. We are focusing mostly on official carers, so people who are registered as carers and potentially also receive cash for care benefits. And we also have some people coming from Carers Association. We did share the link as well. I am happy to share the link with you, but unfortunately the survey is in German, so I don't know if it's too useful, but if somebody does know somebody who speaks German and does care, I would be happy to share the link. And at the moment, we checked the numbers this morning. We are at 1,100 respondents, and we will keep it still open for about 10 days. So I hope that we will have some first results by the end of the month. So what are topics we're talking about? First, it was quite interesting to figure out how carers think about the general impact of COVID-19 in Germany. We asked them about the care situation before COVID, demographics, if you're living in the same household as the person you're caring for. Do you have further support? Is there a professional service helping you? What about neighbors? And in what kind of relationship you're standing with the person taking care of? Then we asked them, how has COVID-19 impacted the care situation and yourself? So are you feeling more stressed, anxiety? How do you try to deal with COVID-19? In addition, we also asked those who are working how COVID-19 has affected their employment status. So has your wage decreased? Are you afraid of being unemployed? Are you allowed? Are you forced to do home office? We think that this might impact also the reconciliation of work and care. So we're trying to look not only at care, but also at the work side of this reconciliation challenge. Then probably the most interesting part is changes of the care situation since COVID-19. So has the support decreased? Are professional care services not coming anymore to your place? What about the neighbors? Do you have less? Do you have more time for care? So one might speculate, if you're doing home office, you don't have to commute anymore for 1 hour. This might give you more resources, more time for caring. And then there's a whole bunch of questions on how it has affected your health, physical, but also mental health. Yeah, we're very much looking forward to this, and it's going to be very interesting to then interact it with gender and socioeconomic status. So one could speculate, one could hypothesize that the changes of care situation have gotten worse, and in particular for women and people from low socioeconomic background. And then we have also item battery on the questions, what would help with COVID-19, more information, more money, free materials. We have a lot in there. We also have one open question, very much looking forward to that one. And yeah, finally, of course, demographics. So far on this study, I took the freedom to make one more slide on another really short, small study, but I think quite fitting. So in another project, which is a cooperation with the University of Frankfurt, I'm doing this together with Navanka, the person on the left, and our two brilliant student assistants, Leah and Carla. And here the idea was to look at students who care. And initially the project started without a focus on COVID, but as we're doing the data collection right now, of course, in the interviews, we're talking about COVID as well. And I did an interview last week, and we have some very interesting results regarding so increases in loneliness, increases in anxiety, in particular related to, like, you know, the person taking care of being a high-risk group. So this triggers, yeah, fears. And on the other hand, it seems that, and at least in Germany, we had this kind of digital teaching, digital studying gave more flexibility to the student carers. So this is kind of a two-sided coin here. And as said, we're also collecting data right at the moment in this project. That was it from my side. I think I was within the 5 minutes. If you have questions, just send me an email. I wrote down a lot of emails already, so I will definitely send out questions. Yeah, thank you very much.
Thank you very much. Remember, all you can use that chat box if you have any questions. I'm making a note to then call them out. Please remember to mute if you're not speaking. I think there's a few people unmuted that I can hear. So yeah, please make sure you reach for that mute button. So our next speaker, now we're back at the UK. We do have quite a few from the UK today. And we're going to hear from Caroline White from the University of Hull. And the study is called Caring from a Distance, Using New and Familiar Means of Keeping in Touch with Family and Friends in Care Homes During COVID-19. Caroline, the floor is yours. Hope you can share the screen, okay?
So our study is looking at how family carers and friends who are carers have been able to keep in touch with people living in care homes through the pandemic. And I can't move the slide along. Are you able to rescue me, Adeline, if I keep talking? I probably need to stop.
I can do it. I can share my screen instead. So just keep talking. I'll find it. And
the reason our interest in this study actually comes from a previous we did around the experiences of what we call distance carers, which were people who were caring for somebody who lived more than an hour's journey away from them when they would visit. And we've just in terms of this study, I wanted to share a few things from that previous research that are pertinent to the current situation. One of those was that when you care at a distance brings additional factors and challenges into play that are not experienced by people who live with the person they support or close by to them, which is not to say it's harder or less hard to care from a distance, simply that it adds some particular challenges to that experience. One of the things that people told us a great deal in that study was they often used a phrase, you can't just pop in. And so if people have worries about their relative, perhaps small concerns, large concerns, they have worries about how to respond in emergencies, how to go in and check out that the person's doing okay, see that everything's all right. That's really difficult when you have to travel long distance to do that. But what distance carers told us they were doing was working very hard to bridge that distance gap. And that was primarily done by traveling to visit the person and by staying in touch between visits, which is nearly always done by phone. But they also told us, they also told us keeping in touch was difficult between visits. And for people in care homes, that was often because although there are very good technologies that we have access to now for things like Skype, people that often needed support to use those, and they didn't always have somebody there who could help them use that. So care staff didn't always have the time or the availability or the skills to help them to use that, and also didn't always have access to things like the internet to enable that to happen. So there's some real challenges about keeping in touch from a distance. And then on to the next slide. We wind forward and find ourselves in the middle of a global pandemic. And in effect, with the closure of care homes in the UK and internationally, we find that in a sense, everybody is now a distance carer, regardless of whether the care home that they're relative in is very local to them or a considerable distance away. They are now in the same position that a distance carer has been in the past, and that difficulty of bridging that distance gap. So everybody needs to find new ways of keeping in touch. And I'm really hesitant to use the term opportunity in this context, but it is an opportunity to find out what works now for the future, because although I do have great faith the pandemic won't be with us forever, there will be localized infection. There will continue to be people who care from a distance or are unable to visit for other reasons, such as their own health problems. So it's really important to think about across the long term how carers can maintain those links with people in care homes. So on to the next slide. Yeah, I just wanted to say that our study is very much looking at the situation of families and friends of people in care homes, but obviously there are two other groups of people that are really important in this story, and one is residents of care homes themselves, and that real need to find out what works for that group of people and what's acceptable and enjoyable for them in terms of contact, and care home staff and managers themselves about what works well for them. And ultimately we need to bring those three perspectives together, but currently we're concerned with the situation of family and friend carers. So what we're doing on the next slide is wanting to know if families and friends have been able to keep in touch, whether that has actually been possible for them. If they have been in touch, we want to know about how they've done that and perhaps new ways they might have tried of being in touch. We're particularly interested in what's worked and perhaps particularly in what hasn't worked for people as well. We want to know if the care home has worked to facilitate that contact, and if they have, what kinds of things they've done which has been helpful, and how the person has responded. I mean, it's really important to hear the care home residents' perspective, and at this point, at least by proxy, it's important to hear how they have responded. So I'm just going to give you a little bit of information about how we're collecting that data, which is on the next slide. Sorry, Adeline. You're doing very well. So we're running, like I think almost everybody else, perhaps partly because of the conditions we're all working in, we are also running an online survey, and that's open to anybody aged 18 or over who's a family or friend of somebody who lives in a care home. That might be an older person, a person with dementia or learning disabilities, physical disabilities, any adult group in a care home or staff setting. We're interested in things like residential communities and supported housing as well. Sorry, I'm just going to wait and get my survey back. Yeah, so any adult living in a care home or similar kind of setting in the UK or in other countries where care homes have been closed to visitors. And glad this is happening to you, not me. And like other people, the survey is currently ongoing. So we're still really interested, and the link is up there if people want to take part or share that link with other people. So I did want to just share. So it felt really not very interesting to just tell you what we're doing, and although we don't have findings, I've had a quick look at the data that's come in so far, and I just wanted to share a few things that were interesting if I have time to do that. So the final slide, Adelina, has a few points which were interesting. After Jackie's presentation, I don't need to share with you that the emotional impact being unable to visit is really hard for carers and the people that they support in care homes. Of the people that have taken part in our survey, the majority have been able to have some form of contact, and for some people that's worked really well. For people that's been quite difficult and challenging and hasn't perhaps worked so well, but some element of contact has usually been possible. We've asked people how they kept in touch before and during the pandemic, and one of the things that's really striking is the emergence of so much more diversity in how people are keeping in touch. So we've moved from people mostly visiting and using the phone, to lots of reliance on perhaps things we didn't expect, like the post for cards and parcels and letters, but also perhaps what we wondered that people might do, which is also more use of online technology. So lots of people embracing new and different ways of staying in touch. Lots of care home residents have not been able to use those technologies independently, so have needed care home staff support. And so the relationships between the residents and the care staff and the care staff and the families comes over as really important. And just to go back to where we started our interest in this area from, in terms of distance, we're finding that over 40% of our participants, which may be partly because of our interest in distance, do live over an hour away from the care home of the person they support, which does really highlight the importance long-term of thinking how people are able to stay in touch. And again, Jackie's story highlights that, of living in a different area. I think you talked about 25 miles away, different lockdowns, and all the impacts that distance can add into any challenging situation. So thank you very much for listening to us.
Thank you very much, Caroline, and apologies for the move. I was trying to click on the link to put it on the chat box, and I realized it wasn't the right time. But if you were able to do that, if you were able to just copy the link on the chat box in case anybody who's in the call would like to follow up.
Oh yeah, that's fine.
Fantastic, and we will.
Thank you very much. Sorry about the slides.
No problem at all. I'm happy to help.
Thank you.
So we now are going to India, and this is a project that has already concluded and it has been published, and we're also going to circulate the link to the article. So I'm very happy to welcome Dr. Sridhar Vaitesaran from SAR, from a group called DemCares in India. And the title of the presentation is actually, you can read it now already, but it's Experiences and Needs of Caregivers of Persons with Dementia in India during the COVID-19 pandemic. You're very welcome. The floor is yours. Thank you.
Thank you very much, Adelina. Thank you very much, everybody. It was really great to see all the experiences so far. So this study, we wanted to look at the impact of the pandemic on the caregivers of people with dementia in India. And so moving on. So we all know about the impact of pandemic on dementia, and there have been a few publications on that. So we know that isolation and quarantine will cause distress for many people, but those with dementia are particularly more vulnerable, and also people with dementia have a limited access to healthcare services and hospitals. So there is an impact on dementia, but I couldn't find, or we couldn't find any particular data on the caregivers early on when the pandemic started. Just to set the scene, to kind of look at the impact of dementia in India, India currently has about 5.3 million people living with dementia. That's approximately, I believe, half the population of London. And the numbers are going to go up in the next few years. We'll cross 1 crore in the next 20 years. So just to put things in context, currently UK has about 1 million and USA has about 5.8 million. So we are very close to what USA has in terms of numbers of people with dementia and so on. So looking at dementia in India, most people with dementia are cared for by their families in their own homes. But there's a huge treatment gap. Nearly 90% of people with dementia are not diagnosed or not receiving their treatment. So it's a huge area which needs a lot of work on. And also looking at the needs of caregivers, even prior to the pandemic, we know that they needed a lot of support, and they expressed a need for improving capacity within the healthcare systems and also having some cost-effective services for dementia. So we wanted to look at the impact of dementia during disasters, and we couldn't find any published study at that time. I know that there are a few studies available right now. So our aims and objectives were to describe the experiences and needs of caregivers of people with dementia during the COVID-19 pandemic in Chennai in India, and also to develop a model to understand their experiences and needs. So just for those who are not familiar with Chennai, here we are in the southeast coast of India. The participants were caregivers of persons with dementia seen within the previous 6 months. That was when we started doing the study in April, May, and so the study, we looked at people who were registered with our service 6 months prior to that. So we had, we kind of employed a purposive sampling technique wherein we wanted as much representation from across various demographic profiles. And we included any family member who's providing care and living with the person with dementia. The person must be aged 18 and above, and the person with dementia must have a confirmed clinical diagnosis of dementia. This is SCARF, Schizophrenia Research Foundation, which is an NGO which has been working for more than 30 years in the field of mental health in Chennai in India. So our institutional ethics committee approved the study, and we actually obtained voluntary consent by using a telephone because of the circumstances. So the consultant psychiatrists who are familiar with the caregivers and the persons with dementia conducted the telephonic semi-structured interview. So the people were familiar with the consultants, so there was no hesitation in sharing information and all that. The interviews were conducted in Tamil and English, and all the interviews were translated and transcribed to English. And 3 researchers independently coded the transcriptions, and then we conducted a thematic analysis, and we arrived at a framework by consensus. So we had about 153 persons with dementia registered and seen in the previous 6 months. And 88 of these caregivers could be contacted by telephone. The rest didn't pick up their phones, weren't available for contact, of whom 56 caregivers agreed to participate. And then we started collecting data, and we stopped at 31 because we achieved data saturation, and also because we wanted this information out as soon as possible. So these are some of the caregiver characteristics from our sample. So mean age was about 54 years. Most of the caregivers were women. And of course, using our purposive sampling, we aim to achieve almost equal representation. So 49% of our other participants were men. And most of the participants were wives of the persons with dementia. About a quarter were sons. About a fifth were husbands, and the rest daughter and 1 grandson. And most of them were quite educated. That's quite representative of the population in Chennai, which has a reasonably high education literacy rate. The mean household income, again, we try to be as representative as possible across the various groups. So we had more or less equal representation from different socioeconomic groups. And looking at persons with dementia, the majority of them had a diagnosis of Alzheimer's disease, a few with other types of dementias. And of course, most of the participants were in the mild to moderate category of severity of the illness. So the results, we could classify them under 2 broad headings: the experiences were, and the needs. The experiences were primarily issues that directly related to their caregiving responsibility that was impacted by the COVID-19, and issues that did not relate directly to their caregiving responsibility, and then looking at their immediate needs and the longer term needs. We'll explain that in a minute. So looking at the unique issues that the caregivers experienced during the pandemic, where all the things which previously has been alluded to, and many of our caregivers reported that, the main concern that many caregivers had was about protecting the person with dementia from being infected by the coronavirus. And many of them had a lot of worries about the person with dementia refusing to wash hands or refusing to wear a mask and all that, or restricting them within the house. That was a big issue. The other major concern that the caregivers had was about if the person with dementia were to be infected, how could they be managed in a generic facility for managing persons who are positive for COVID? Because the requirements for persons with dementia are quite unique, and they were worried that the caregivers would not be allowed to visit them. And looking at the day-to-day activities and day-to-day routines of persons with dementia being impaired, and dealing with the changes that was happening associated with that. And many caregivers had a lot of concerns about that. Many of the routines had been changed, as you're aware. The day centers closed, and many public activities had stopped. People couldn't go out for walks. They couldn't go out to parks for walks and all that. So there were lots of changes, and many families expressed a lot of concern about that. The other big concern was unrelated to dementia, the general health and well-being of persons with dementia. So if a general physical condition of the person with dementia was to worsen, where to worsen, what could they do? And many of them had concerns that they couldn't contact their usual medical services. And the other big concern was lack of exercise and lack of ability to go out for walks. So the police were asking people to go back home if the person with dementia were to go out for walks. And that was a big concern for many families. And of course, the major challenge that many families reported was managing the behavioral and psychological symptoms that came with being restricted in the house and not being able to carry out their routines and activities. And so that had a significant impact on many families and caregivers. So these were the unique issues that related to caregiving and the pandemic. But when you look at the caregivers and other concerns that they talked about, these were not unique to the dementia caregiving responsibility. This was something which everybody shared who lived in the community, but also had an impact on the caregiving. So managing daily household chores and supplies, everybody faced in the city, but specifically for those caregivers who are looking after those with dementia, they had particular concerns about how could they manage this in addition to looking after someone with dementia. And of course, looking at disruption at work and financial problems, the caregiver's own health and well-being, not being able to access medical help when they need, and then the worries about the caregiver being infected and quarantined and what would happen to the person they are caring for. So who's going to look after them if I need to go into the hospital? So that was a big concern. And of course, the biggest concern that many families had was about stigma. Stigma about being infected by COVID. And that was particularly problematic because the local authorities here were sticking notices in front of in the front doors of people who had positive COVID-19, and that practice has resulted in a lot of stigma about COVID and a lot of shame about being infected with COVID, and that resulted in a lot of concerns. And many families didn't want this, and they were worried about this. Already having someone with dementia carries a lot of stigma, and on top of this, this added to the problem. So this was something which many caregivers discussed as a big concern for them. So when we looked at the model, so we had two issues. The main issue was issues that were directly related to caregiving responsibility due to the COVID. And then the issues that did not directly relate to caregiving responsibility. And these two actually had an interaction with each other. And then they resulted in the needs. They generated a lot of needs for the caregivers. And of course, we need to discuss about, they had a lot of input about how the needs could be met under the circumstances. The needs were immediate needs, which looked at engaging the person with dementia at home. So how can we look after this person? They are getting agitated when nobody is spending time with them. So how do we do that? And then assistance at home for managing their day-to-day activities. Need for consultation with specialists and doctors and nurses. So they had a lot of issues about this, and access to medicines for dementia. And many of the pharmacies were kind of unable to deliver specific medicines for dementia because some of them were receiving medicines from a specialist pharmacy in our hospital, and they didn't have access to medicines during this period of time. And of course, a lot of them had a lot to say about a flexible implementation of policies related to COVID. We'll come to that in a minute. Now, many of the families also had long-term needs looking at post-pandemic. They also looked at, they needed trained home care support, caregiver training. They wanted respite services and better awareness in the society. So looking at implementation of policies, I've kind of presented here two case scenarios. One of them is about a person with dementia who was getting very agitated, living in a small apartment. Previously, this gentleman could go out for walks, and that resulted in less agitation and restlessness. But unfortunately, due to the lockdown, he was restricted in the house, and a family actually applied for a permit. In India, you needed a permit to travel within the country. And unfortunately, their travel permit was declined because dementia was not considered a medical emergency. And the caregiver said that the authorities didn't know much about dementia when he approached them for a special permit. So this raised a lot of anxiety within the family, and the gentleman continued to become more agitated and restless. And in fact, that affected this gentleman's work from home. The son, who was the main caregiver looking after this father with dementia, was working from home. He was a software engineer. He couldn't work because the father was agitated and preventing him from doing work. So it had an economic impact as well. So this is something which need to be discussed in the longer term. There was another policy about delivering goods in areas which were under lockdown, and non-essential items were not being delivered. Online delivery was stopped, and many of the shops were closed. There was this gentleman who used to scratch his scalp a lot, and the family was managing this by giving him a soft toy, which he used to scratch. Now, unfortunately, this soft toy, I mean, they need to change this very frequently, and because he was scratching it constantly. Now, this toy was worn out, and they couldn't access any shop or online delivery like Amazon. They couldn't contact the services to get a new toy, and this person was scratching himself a lot at this point in time. So the family was very concerned about this. So the implementation of policies has to take some of these issues into account later on. So we looked at the caregivers asked about providing support during this time, and many of them talked about providing support by technology, using video calls and telephone calls. But not all of them were happy about receiving services in this way, and mainly because of many of the families had concerns about using technology. The elderly person who was the main caregiver didn't have access or experience to use technology, and that was a big concern for many of the families. And of course, those from lower socioeconomic status didn't have access to technology, so that is a big issue. And of course, the more advanced the dementia is, the more severe the dementia is, the person with dementia is not able to participate in any online engagement processes. So many families had problems with that. And of course, ease of access. So there was a couple of people with dementia who were living very close to the hospital. They thought there was no need for an online service. And there was no perceived need immediately that could only be met by using technology. So these were some of the main reasons why families thought they didn't need to use technology. And of course, many families needed clinic-based inpatient, in-person visits. So they could come to the clinic and see a doctor, get a prescription and all that. But of course, this was limited because of lack of public transport. So people have to choose their own means of transport to come to the clinic. And of course, everybody has to wear a mask. And of course, persons with dementia would refuse to wear a mask, and that was a major concern. And of course, the doctors have to wear personal protective equipment, and that resulted in limited access, and people couldn't understand very well. The voice were muffled, and it was very hot during that period of time in India, so you couldn't wear a PPE for a longer period of time. So all that were issues that we had in delivering a service in the clinic. And of course, increased availability of services post-pandemic was something which many caregivers talked about. So in concluding, the caregivers face special challenges in looking after someone with dementia during the pandemic, and they must balance these with the challenges that they share with everyone else during this time. So access to services and all these things were something which was a big issue. So supporting these caregivers requires a pragmatic, multi-layered approach. The use of technology can be helpful, but that is not going to answer all the problems. So we need to have, for some, we need to use technology, but for others, we may have to use in-person service delivery, but using appropriate protection. But for some, you may have to use technology along with in-person services. And also there has to be a systematic change across how the services are being delivered, looking at policies and frameworks. There has to be raised awareness, increased awareness about dementia amongst policymakers and policy enforcers. We talked about use of technology and better access to health where necessary. But a lot of work needs to be done in this area, because this is not going to be the last disaster that we are going to see. There are going to be hopefully fewer, but we will see more disasters in the near future. The limitations of this study was, of course, there was one study done in one clinical service providing dementia care in India. And we could only contact those who had access to telephone. So we didn't have access to people who didn't have a telephone. So we don't have views of those people. And of course, we need to explore how best to provide interventions and support caregivers and persons with dementia under these circumstances. Now, this is an iconic landmark in Chennai. And I just this was by the beach. And I clicked this photograph. nice kind of to look at a rainbow. There's a rainbow at the end of every storm. So this is a crisis, of course, and we will see something good and positive coming out of it. And if it means better services for people with dementia, then it's good. And of course, I need to thank all the participants. Some of the caregivers who participated in the study are actually in the meeting today. And a big thanks to the wonderful team who participated and who helped in completing the survey. And that's our contact. And of course, the paper is available online, and feel free to contact us if you have any questions. Thank you very much for the opportunity.
Thank you very much, Sridhar. That was a wonderful picture with which to end. And it's amazing how some of the issues that Jackie raised at the beginning are now being picked up as well in your research in India. So we're seeing all over the world very similar issues for the carers, in this case of people living with dementia. There's quite a lot in the chat box. We usually go on until 1:30, so we've got about 9 minutes now. Today we spent longer on presentations. There's been a bit of a discussion, and it's been very interesting that this one last presentation was done on the telephone because all the others were online. And there's been there's been a question about, how do we reach the people that we cannot reach online, and Sridhar, you explained very well all the difficulties. And then I noticed I'm going to invite Caroline White, because I saw in the chat that you explained some of the difficulties as a researcher in terms of trying to practically do any other method in your case. So would you like to come in and explain a bit your, how you found it when you thought about doing perhaps post interviews?
Yeah, it was sorry, can you hear me?
Yes.
Yes, it's a real challenge that we found when we did the original distance carer survey. We had a paper-based survey that we could send to people as well. Very few people wanted to use it. I think only 2 or 3, but we did have that option available to us. I'm not sure what the situation is for people internationally, but in the UK, most university campuses are closed, which raises a really difficult question about where do the surveys go in order that they're safe, both so that they don't get lost. Our survey is anonymous, so it wouldn't be too much of a problem in terms of personal contact details, but people might add them in, but also just losing data that people have taken the trouble to share. And that for us became the difficult area. We hadn't set it up as an interview study. We had some concerns about doing that in terms of the depth of questions that we might be asking people at a time when we weren't able to meet them face to face. So there were lots of dilemmas and dilemmas that we didn't really effectively resolve. So the only thing that we've added in, and there's been an interesting comment about doing the survey with people over the phone, which is another way that might work. But for us at the moment, we have ended up in a situation where we're doing it either online, or people can request an emailed version of the survey, so that if they don't like doing things online, that doesn't feel secure, they have another route in, but it isn't satisfactory. And it means that we're not hearing from people who are not familiar and comfortable with technology, which is a really important group of carers to reach. And the only thing that might be possible is to pick the survey up again, perhaps when life is a bit more normal in a retrospective way, so that people can have that option of writing in if they want to, when that data is safer. So it's a real challenge for everybody. I don't want to sit here saying it's a challenge for researchers when we're talking about carers' needs, but bringing in carers and being really inclusive is an additional challenge in research just at the moment, because of the conditions we're all working in.
Thank you. I'd like to invite somebody whose initials are TB. Because you mentioned in the chat that you are considering what to do, which birds to use in a study. Would you like to comment? Don't feel pressured, but we'd be very happy to hear about this new study.
Hi, I'm not going to show my video because I haven't brushed my hair today. So my name is Tammy Boyce, and I'm working with the WHO office in Venice. And I'm managing a project looking at vulnerable populations in Italy and the impact on 2 populations, looking at those living in poverty and also the elderly. So we wanted to do some kind of, there has been a survey done on carers, but we wanted to do some kind of training. And I guess I came to this because I wondered if anyone else had done some training because that was the main finding from a survey that they have done on Italian carers, is they're desperate for some kind of training about what to do. And I guess I was quite interested in Sridhar's findings because he sort of indicated some of what people wanted. But I would just be curious to know, yeah, if what kind of training can you provide to carers when often so few of them, especially when we're talking in quite older age groups. I don't mean just over 65, I mean some of the older 85s, you know, that age group. What people know is available.
Would anybody have a quick answer with an example or something helpful you've come across? I see heads that go side to side, so not yet, but if any thoughts come up, at LTC COVID, we're very happy, and there's a contact form in the website to share any examples or resources. So if you've got anything you'd like to share and you don't tweet, you can always either email or send fill in a contact form on the website. I'd like to then, because we're almost at the end, I'd like to end by, if Jackie, if you're happy to come back again. I was wondering what are your reactions to what you've heard so far in terms of what this international research is showing, and also the kind of studies that are being developed. Is there anything missing, any key messages that you want to stress, any thoughts that you might want to share in reflection?
I think just I just find it, you know, I'm quite overwhelmed that there is so much going on. It's something that we've been wanting to happen for such a long time as a group. You know, from a dementia sufferer point of view, but also from a carer's point of view. You know, I do feel as if coming together as a bigger organisation, and you know, all the different countries and everything, just coming together under that umbrella, it just gives you a bit more hope for the future, really. You know, and any research that anybody's doing, you know, we've got quite a strong group of carers with lots of different experiences, and if anybody wants to tap into us as a group, a ready-made group, then, you know, please feel free to reach out and contact us, you know, because we want to do everything that we can to get the coverage and exposure that we need for dementia and carers.
Thank you very much. And I'd like to also give a special thank you to all the other carers that I understand are in the group. And let me see if maybe I'm going to squeeze in one final point, because that was one of the first comments we had from Michael Clark, which was about the specific pressures on single carers with no additional support from any areas. I don't think we have a quick, fast answer here. If somebody does, please raise a hand, let me know. But I think it's definitely a really important issue, and that the more support the carer themselves has, the easier the task becomes. And I think it's really something we need to pay a lot more attention to. And I'm hoping that all this rich research, all these projects we're hearing will help make a difference, and showing the impact that this pandemic, but also all the previous situations that were already not so good, that were services were already not enough. So thank you very much. Everybody who's presented on ongoing studies, we'd love to hear from you in about a couple of months. I know some of you will have already be in the middle of analysis, some of you will have maybe concluded. So you're all very welcome. If there are other people who would also like to share their views, even your personal experience, we're really happy to hear from you. So please be in touch. We will come back to the topic of carers. We may discuss other things in the meantime, but given that most of the care is provided by unpaid carers, any project, any initiative that looks at long-term care needs to put family carers at the center. So thank you all for everything you do, for sharing, and for listening, and your excellent engagement and comments. We will take a break at LTC COVID. We'll come back at the early September, and we will announce the topic through the usual channels very soon. Thank you, and if anybody who's having a holiday of any kind, be it while doing everything else, please enjoy. Thank you very much. Bye.